disclosures, as told you already, end of April, 1st of May. Reason, no clear evidence. You see here the faculty, and we had also active participation of ASNDS, WOF, EASO, and IDF, and I think really very balanced faculty. So the core group consisted of me, Ricardo Cohen, who followed me in the position of IFSO president, and Luca Busetto from EASO, and we of course took the help of a professional Delphi expert that is Randy Levinson from the US, and Chetan, together with Mohammed, did a systematic review on the entire field. A tremendous work. I'm very grateful to these two guys. Thank you, Chetan, once more here. And we sent out that systematic review to all the experts, the relevant papers, so to bring all the experts to the same level of knowledge. And then each expert had to define 3 to 4 Delphi statements. We ran 3 online Delphi rounds, and the most interesting or conflicting ones then were dealt with in Vienna. In Vienna we had 3 modules. One was considered the use of obesity managed medication before metabolic bariatric surgery. Why did we call it obesity management medication? Because the patient's advocates claimed that anti-obesity medication is stigmatizing language. So there was a huge discussion. It ended up with obesity management medication, OMM. I think that's a very appropriate term. Second module was the use of OMM after MBS, and you see again a lot of internists talking, like Lee Kaplan, Dortica, Josep Vidal, Karel Leroux, and so on and so on. Matthias Blüher from Germany, also very, very well known, and many others. And they too, we ran the Delphi process. Of course, some statements seem to be very easy. I won't chase you now through all the statements. I pick out a few that might be interesting for you. For instance, that one. A minimum of 5% weight loss has shown metabolic improvements. However, greater weight loss is associated with broader clinical benefits, including a reduction in mortality. Sounds reasonable. Why did we need 3 Delphi rounds to get the results with 97%? The literature behind this, there's very well known that obesity affects all organ systems. There is a dose dependency. Of course, the more weight you lose, the more tissues are affected, with more effects on different tissues. And this also came into the play when we look at the definition of suboptimal clinical response that was considered by 20%. And you see from many well-known studies like the Finnish diabetes prevention study, I just highlight the outcome: more weight loss, less diabetes, direct study, more weight loss, more diabetes remission, look ahead, greater weight loss, greater health benefits. Select trial, I'll come to that in a second. 9.8% total weight loss leads to 20% less combined cardiovascular outcome. And this maybe was new, and you see here, of course, big numbers, very excellent study, patients with age 45 more, BMI of 27 plus, and you can see that for the semaglutide group, the 20% improvement in the cardiovascular composite endpoint was reached with 9.8% total weight loss. So how much weight loss is required? You see most of the benefits are up to 20%. Of course, body image, you need maybe more, up to 40%. And also metabolic bariatric surgery as a prevention of cancer. Very nice data, maybe just to pick out Ali Aminian's paper here, where you can see that in the quartile that lost 24% total body weight after, I can't read it from here, I think it was 10 years, you have 6% cancer incidence, but in the highest weight loss group, it is much, much lower. So the more weight you lose, the less cancer you get in the future. So metabolic bariatric surgery also as a cancer prevention strategy. And this led to this statement: a minimum of 5% has shown improvements, however, greater weight loss associated with broader clinical benefits, including a reduction in mortality, cardiovascular, but also cancer mortality. There is insufficient weight loss, insufficient high-level evidence to recommend the routine use of OMMs for weight loss before metabolic surgery. This is unfortunately true. I won't chase you through all the papers. A lot of these papers is given for all obesity management medication. We have only a few for the new one. Nevertheless, at the moment, there is not enough data to tailor the choice of OMMs for patients with diabetes, with obesity. Nevertheless, we can think, of course, about a few patients that might benefit, especially from the use of OMMs before metabolic surgery, those with a high perioperative risk, let's say very high BMI, and of course maybe also to increase the proportion of those achieving weight loss goals and comorbidity resolution after surgery. We should of course maybe turn this term replaced by obesity complication. How does that come? I give you one paper, 500,000 patients, and you see when you lose weight before surgery, you decrease the number of leaks, you decrease the number of mortality, and again, dose dependent, the more weight you lose, the better it is. But this is a dangerous paper, of course, because if the insurance provider reads that paper, they mandatory ask for weight loss before surgery, which might be beneficial for high-risk patients, but maybe not for all groups. So it's a very dangerous paper, and that led in the very end to a position statement from the ASMBS that we should not delay surgery. This is also not beneficial for the patient. At the very end, I think the multidisciplinary team should really define the best time point for the metabolic bariatric surgery. So decision to use OMM before metabolic surgery should be personalized, and again, for each patient's circumstances, special circumstances, high BMI, advanced liver problems, advanced kidney problems are examples for it. But keep in mind, with the new OMMs, we achieve weight loss that might be similar to metabolic bariatric surgery. So what we will see is the same problems, a loss in lean body mass and also deficiencies. And we heard today already that 95% of those prescribing it are maybe not obesity management specialists. So I think we will see many more problems in the future if OMMs are successful on the long-term run, which we have not seen, by the way, until today, but I'm also looking forward to see that. In general, preoperative treatment with OMMs should be discontinued prior to metabolic bariatric surgery to minimize the perioperative risk. Where does this come from? This comes from the fact that, of course, GLP-1 receptor analoga delay gastric emptying, you have an increased risk of aspiration. This is only level 3 evidence, but at the moment, this is the recommendation from the American Anesthesiologists Society. Treatment with OMMs after metabolic surgery should generally be withheld until the achievement of a weight plateau. This was also one question. Why? To be able to differentiate the effect of metabolic surgery and the effect of obesity management treatment. So it makes sense to wait until the weight plateau. But there are again certain treatment modalities where we could combine it from the beginning. I will come to that in a second. So, yeah, that's what I just said. In case of suboptimal initial clinical response and in case of recurrent weight gain, you start, of course, with the OMMs. Where does this come from? I will chase you very quickly through the Gravitas trial. It makes sense to use liraglutide in case of diabetes relapse, and of course also mentioned yesterday already the very famous trial from the group from Rachel Betterham and Mock, and again you see that treatment with liraglutide in poor responders makes sense. So for patients requiring OMM to maintain a healthy weight after MBS, their ongoing use of medication is likely needed. We all know that from the SURMOUNT 4 trial, you stop, you regain, and also from the STEP 1 extension trial, if you stop the obesity management medication therapy, of course, you regain the weight, so this is not a big surprise. Identifying predictors for patients who could benefit. These patients could be, of course, obesity class 5, progressed liver disease, progressed diabetes, progressed kidney disease. What I mentioned before, and also was said already yesterday and today, we operate only on less than 1% of eligible patients. Why? Patients are afraid of surgery, unfortunately. So we could think of surgical and endoscopic treatment modalities that are maybe less invasive, maybe also less effective, but combine it with obesity management medication. And that was done in this study. You can see that the combination of an endoscopic sleeve gastroplasty with obesity management medication leads, of course, to a better weight loss outcome. This is not a big surprise, but you see also that this statement, the benefit of endoscopic therapies for obesity can be enhanced by combination with OMMs, was very controversial. Only 74%, we needed 2 rounds, it was rephrased several times, only grade C, but it reached at the end consensus. Emerging evidence indicates that the weight loss induced by OMMs is similar among people who have had or not had MBS. This is important. So you could argue that patients that have successful metabolic bariatric surgery already an increase in GLP-1. If you put them on top GLP-1, they don't respond better or worse. It doesn't seem true, and the evidence we have until now that also for the new OMMs, the weight loss seems to be similar. Also not bigger, one has to say. When used after metabolic bariatric surgery, there appears to be no increased incidence of side effects, also not a big surprise. So the typical side effects seems to be the same. And the long-term efficacy and safety is of course unknown. We need further studies. The majority of the studies end with 2 years. We've heard already maximum 4 years. And this is maybe one of the most important statements for patients with recurrent weight gain. Treatment with available OMMs should be considered prior to revisional surgery. Before we do revisional metabolic bariatric surgery, the patients should have a treatment attempt with the new obesity management medication. Why? Because the weight loss you can achieve with it is around 50 to 75%. Of course, again, we have no long-term data, but keep in mind that revisional metabolic surgery does have a higher morbidity, and honestly speaking, as a surgeon, we don't have any long-term outcome. Long-term, I mean 10 years. We could even say no good 5 years data for revisional metabolic bariatric surgery, unfortunately. Yeah, again, a big topic is of course access to the new medication, cost, availability. These are all topics that are not solved until now, and this is of course for policymakers, access to treatment, availability, willingness to pay. And I stop here. The willingness to pay threshold is much higher. It should come down to $6 per day, then it would be cost effective. And I think I'm already much over time. This is again the group that met in Vienna, and today the results of this consensus conference is published in British Journal of Surgery. By today you can download it, and there is also a systematic review, and Alex is the senior author of that paper, and also an editorial, and download it, read it. I think it's definitely worth it. I want to invite you to Venice next year and to Santiago de Chile for the World Congress, and I thank you very much for your attention.